we just heard the initial results of the RISE trial, the pediatric medication arm. This was an exceptionally well executed study, very hard to conduct, but done exceptionally well. Unfortunately, with some disappointing results, which doesn't mean that we haven't learned a lot. But we don't know how to prevent or treat dysglycemia in youth yet. The reason this study was conducted, as we heard today, was because we've witnessed in the last 20, 30 years rising prevalence and incidence of type 2 diabetes in youth from studies such as SEARCH and others. To ever-growing proportions. Yet everything we know about type 2 diabetes in children is by extrapolation from what we know about type 2 diabetes in adults. So the RISE study really tried to compare head-to-head adults and youth with impaired glucose tolerance and early onset type 2 diabetes, or newly diagnosed type 2 diabetes. First of all, to understand whether type 2 diabetes is similar in children and adults. And then it tried to test two different approaches to treatment and prevention. One arm was metformin, the other arm was insulin for 3 months, followed by metformin for up to 12 months. With the goal of determining which of the two is going to do better at preserving insulin function at 15 months from randomization. So both treatments ended at 12 months, and the primary outcomes were various measures of beta cell function at 15 months. So we saw today the results in the pediatric medication study. And unfortunately, insulin function deteriorated in youth with dysglycemia and newly diagnosed type 2 diabetes progressively throughout the entire duration of the treatment and continued to deteriorate up to 15 months with no differences by treatment arm, suggesting that neither metformin alone nor glargine plus metformin are going to preserve insulin secretion and beta cell function in youth with dysglycemia, which was the disappointing finding. Some of the other things that we learned today had to do with how youth with dysglycemia compare against adults with dysglycemia at similar degrees of obesity and with similar demographic characteristics such as race, ethnicity, and starting glycemic levels. And that comparison was extremely interesting because we learned for perhaps the very first time two important things. One was that youth with dysglycemia are much more insulin resistant than adults with dysglycemia at similar levels of body mass index. About half of the insulin sensitivity levels that adults have were seen in children. And the other piece of new information was that perhaps not unexpectedly, youth with dysglycemia have a very responsive, actually hyper-responsive beta cells as compared to adults. So they almost hypercompensate for their insulin resistance at any BMI level. What do we do with these information? There are several things to consider. First of all, the head-to-head comparison of what happens with these two interventions in youth and in adults is yet to come. We haven't seen the results in adults. We think from prior studies that in adults with dysglycemia, metformin prevents deterioration of beta cell function. We've seen that in the DPP. But we have never done a study like this with exactly the same types of measurements taken in youth and adults. So I'd be curious and interested in seeing exactly what happens with adults and whether adults do better than youth and which of the strategies is better at preserving beta cell function. We haven't seen that yet. The other thing that I think was a little disconcerting was the fact that what we saw today in children did really not make any physiological sense. So indeed, we have to try different medications that are available in adults and are not available yet in youth because they're not yet approved. But the results today make me wonder whether anything pharmacological that we have today on the market will be successful at preserving or improving beta cell function in children. Obviously, we have some evidence that weight loss might matter, and that's certainly something we need to explore more. We shouldn't necessarily not think about the surgical variant as well. So yes, the results in adults are expected with great interest. The results in the surgical arm of the study are expected with great interest because that might be something we need to think about for children. And really, to me, the bottom line today was that perhaps to prevent type 2 diabetes in children, we have to move from an individual level approach to a population level approach and address the issue of how to really prevent obesity, reduce obesity, and offer what we call primordial prevention that would really shift the curve of obesity and associated dysmetabolic consequences to the left, and have less kids with diabetes because we didn't used to have them in the past when the world was less obese.